Actually, please, if you can stay, we don't have a break. Just a minute, please. So I would like to, we don't have a break between the first session and the second session. We move right away to the second session. Dr. Croker and Dr. Riaz, if you don't mind to come over. Thank you very much to start the second session immediately. Thank you very much. I just want to remind everybody also immediately after this session, this is going to be a short session. We'll have a group photo. So Dr. Croker, if you don't mind to come and lead the second session with Dr. Riaz.
All right, let's move right on. We have a whole hour to speak about lung cancer. Probably the best part of my day, and it's my birthday. So I'm very happy to introduce Julian, Dr. Molino, professor of medical oncology at Mayo Clinic. And we collaborate a lot in St. Elizabeth with Mayo Clinic with e-consults and e-tumor boards. And I enjoy his wisdom and advice. He will talk about early lung cancer. That's the first part. And then later on about small cell lung cancer. And then Dr. Agarwal will talk about metastatic non-small lung cancer. So Julian, go right ahead.
Well, thank you very much for the invitation. The University of Cincinnati is my alma mater, so go Bearcats today. When I was here, this was a softball field. This building was not here. The molecular medicine building was not there either. So again, very happy to be here. I went yesterday to get Skyline chili and I'm still floated. So, but again, I don't regret that. I'm gonna talk about early stage non-small cell lung cancer if I can figure out how to manage this. Very good. I'm a Mayo Clinic employee, so nothing to disclose is the rule at Mayo Clinic. And that is sad because I'm still paying for my kids' student educations. But I'm going to talk about why it's important to consider treatment for early stage non-small cell lung cancer with chemotherapy or immunotherapy. If you look at the survival rates, it drops significantly from a stage 1A1 all the way to stage 3. So this is really dramatic. So we have to do better than this. The treatment of early stage lung cancer nowadays is not just surgery, by the way, it's either surgery or radiation therapy. And then for patients who have surgery for stage 2 or have lymph nodes that are involved or risk factors, those patients go ahead and receive adjuvant chemotherapy. Stage 3 is a different beast. If you know how to treat stage 3 lung cancer, you know lung cancer. So this is treated with either neoadjuvant chemotherapy, chemotherapy plus radiation, followed by surgery, or surgery followed by some sort of adjuvant treatment. Now, we now have evidence that doing surgery using VATS is as good as doing an open thoracotomy. And that evidence is coming from this study. This was presented at ASCO this year. They look at 247 patients and 256 and compared the outcomes of VATS versus open lobectomy for early stage lung cancer. They actually look at a really nice outcome, which was the physical function of the patient at 5 weeks and a year. And you see at 5 weeks, this is the Kaplan-Meier. You see on the left how the patient who had VATS had a better functional status. Finally, at the end of that year, the functional status of the patient who have the thoracotomy catch up with the open with the VATS procedures. In addition to this, there were more readmissions and more serious adverse events in the thoracotomies. Survival, at least the preliminary data that they have, is not compromised by having a VATS surgery compared to an open thoracotomy, and progression-free survival is the same. Now, there is more evidence nowadays that doing treatments with radiation for early stage lung cancer is as good as doing a surgery, and that it was initially presented years ago. The results of the STARS and the ROSELL study showed that the outcomes, when you look at overall survival and progression-free survival, were almost identical. What they did this year was that they had new data where they expanded the group of patients that were treated with radiation. And for those patients, I don't know if there's any radiation oncologists here, the guidelines now call for 50 grades in 4 fractions if you have a central tumor, or 54 grades in 3 fractions if you have a peripheral tumor. When they look at the outcomes were actually slightly superior than the outcomes from surgery. And not only overall survival is not compromised at 3 and 5 years, but progression-free survival remains pretty good. The numbers actually prove the point. At 3 years, for the group of patients who received radiation therapy, 91% of those patients, that was the survival. For surgery, 91%, very similar. At 5 years, the numbers tend to favor the radiation therapy treatments, 87 versus 84%. And you see below that, the data for progression-free survival also almost identical. So the two modalities are pretty much the same, and these are for patients that are resectable, not just for the patients that are not resectable. Now, how about giving chemotherapy or some sort of treatment for someone who is just diagnosed with early stage lung cancer? It took me a while to find the paper, but this is Jack Roth, the surgeon from Memorial, and the paper is from 1994. And what they did was a study where they look at patients who received chemotherapy before the surgery. And what you see in the upper line is those patients that receive perioperative chemotherapy, and even the perioperative chemotherapy for the resectable patients was much superior as far as overall survival than if those patients did not receive surgery. Now, the study was criticized because of the low number of patients. So other studies were done, and one of these other studies was the NATCH trial. And this trial took about 400 patients and randomized those patients to just surgery or surgery followed by chemotherapy, giving chemotherapy in the adjuvant setting or giving chemotherapy in the neoadjuvant setting. You can see that the option for the chemotherapy was probably not the best one. We now know that paclitaxel is inferior to cisplatin, but it was, I'm sorry, that carboplatin is inferior to cisplatin, but it was Taxol carbo what was given. And unfortunately, there was no statistical difference in disease-free survival for the patient who received the neoadjuvant treatment or the adjuvant treatment when compared to surgery. So the problem with these studies is that all of these studies is the studies that we did as part of the cooperative groups. And for those studies, it took a long, long time to get results. What I have on top is some of the cooperative group studies looking at the adjuvant chemotherapy. You see 9, 10, 12, 13 years to complete those studies. And then for the neoadjuvant trials, 10 to 13 years also to complete the study. So using that endpoint or waiting until you have the mature data for the overall survival is really difficult. And what we needed was kind of a change in what is that we're going to look as an endpoint. So how did we get to where we are now? We got there by learning from the colorectal cancer patients or from breast cancer. And by the way, they are now learning from us. Where the action is nowadays in oncology is in thoracic oncology. If you look at the improvement in mortality in this country has been driven by 2 tumors, melanoma and lung cancer. It's not the FOLFOX and the FOLFIRIC eyes. So this is what was taken. Look at the tumor after the patient is exposed to some sort of therapy and look at that pathologic responses. So you measure the tumor and then you determine what is the percentage of tumor cells that are alive in that sample. And based on that, there is what we call a major pathologic response. That is, if you see more than 90% of the tumor cells dead and only 10%. And a complete pathologic response is if you don't see any tumor cells in the specimen. So these are the two kind of drivers. And these are very good surrogate points for overall survival for the group of patients. So we don't have to wait until the overall survival data matures. You can just look at how is the patient doing at the time of the surgery once that the patient is exposed to a given treatment. And one of the first studies that actually incorporated this was the LCMC3, a study out of Memorial, and that you can see very detailed study. They were doing a lot of imaging studies, and then patients were receiving just 2 cycles of nivo. And then after that, the patients were taken to surgery. Before that, the patients got more imaging studies, then surgery, and then there was optional adjuvant atezolizumab for this group of patients. The primary endpoint was what is the pathologic response at the time of the surgery? And as you can see here, 15 or 77 patients got a major pathologic response. Again, this is 90% of the tumor cells being dead at the time when the pathologists look at the surgical sample. 4 out of 77 patients actually had a complete pathologic response, and this is just 2 cycles of nivo. So again, very promising results. The other thing that we learned from this study is that these pathologic responses correlate with what we see on the scans. So the scans that were done right before the surgery had a good correlation with the findings from the pathologists, indicating that it was safe to give these treatments as long as you were following the patients with good imaging studies. And then another study came. This is the study that Manu Provencio presented. And this was given just neoadjuvant, not just immunotherapy, but adding chemotherapy. So we know that immunotherapy alone, even those 2 cycles of nivo was working fine. How about if we add chemotherapy? So this is nivo plus carboplatin and paclitaxel given for 3 cycles, and then patients were taken to surgery. And I pointed to the major pathologic responses. You can see the numbers, 86% of the patients having a major pathologic response, and then 71% of the patients having a complete pathologic response. So big gain by adding chemotherapy to immunotherapy. And again, using that surrogate endpoint of pathologic response as a predictor of overall survival. Now, the other question when you do this kind of approach is, are you going to compromise the surgical outcomes? Is it safe for the patient to wait? You know, I'm just diagnosed with lung cancer. Let's say I have a stage 2 lung cancer. Is it safe for me to wait? Am I going to have more complications at the time of the surgery? What is going to happen to me? And this study was presented at ASCO this year, showing the complete pathologic responses that you see based on different stages. You can see the high numbers, and that's compared to chemotherapy only. Big difference between the group of patients that receive chemo plus immunotherapy versus chemotherapy alone. And then the pathologic regression actually correlates very well with what you're seeing at the time of the surgery. Now, these are the complications. So the potential complications that can happen to the patient during surgery or after surgery is not increased by being exposed to a regimen of chemotherapy plus immunotherapy, indicating that this is really the way to go for the future. So this is where we are. We have quite a few clinical trials open. I pointed to the 2 trials that we have open at our institution. I'm the PI for the Keynote 671, and the study is really accruing very well. What you need here is really have good relations with the surgeons, because these are patients that we, the thoracic oncologists, usually don't see. We see those patients if they have lymph nodes involved or they have risk factors to have that discussion about the adjuvant chemotherapy. So it's the surgeons the one that have to refer these patients to you, and the surgeon has to be compromised for these studies that the patient is going to go and receive 3 to 4 cycles of chemotherapy, have a surgery, and then start some maintenance treatments. So all of these studies are basically designed with the same kind of backbone. Patients have chemotherapy plus placebo or chemotherapy plus immunotherapy for 3 to 4 cycles. Then they have the surgery. And then after that, and this is painful because you end up who is getting immunotherapy, who is getting placebo. After that, there's a year of either immunotherapy or placebo. And we're waiting for the results of this, but this is going to be the way of the future. I think immunotherapy plus chemotherapy has shown to work very well for lung cancer. And I suspect that we're going to have this in the front line. Now, how about the patient who have surgery and then you learn after the surgery that the patient either has a driver mutation or the patient does not have a driver mutation? Is there a need to consider something beyond adjuvant chemotherapy? Let's look first at the group of patients who have a driver mutation, and you all are familiar with the ADURA trial. And this is a trial where they look at disease-free survival and actually got FDA approved for Tagrisso, but there's no overall survival benefit that we're seeing so far. I'm sure that the company is looking at this data, and one of these days they're going to release it. So it is unclear if giving Tagrisso or osimertinib for 3 years is curing the cancer for this patient who had resected lung cancer, or it's just delaying the recurrence of the disease. We don't know. And we don't know if 3 years is going to be enough. We don't know if these patients are going to need to be on this inhibitor for a longer period of time. But this was the design of the ADAURA trial. Patients who have stages 1, 2, and 3 lung cancer, they have an EGFR mutation. They were randomized between osimertinib or placebo for 3 years after completing adjuvant chemotherapy for the ones that there was an indication for adjuvant chemotherapy. And then they follow these patients. The primary endpoint was investigator-determined disease-free survival, and the study was positive. And I wanted to bring the hazard ratios first, because this is kind of telling you that this was a very positive study. If you see the hazard ratios, they are all less than 0.4. There was only one for early stage where you really, the number is not the best, but still the hazard ratios are 0.4. And please keep in mind this for something that I'm going to present later. And then when you look at disease-free survival by stage, probably the stage 1B did not gain much, but stages 2 and 3A, there was a significant gain, at least on disease-free survival. There was also a significant gain on the estimated probability of getting brain metastasis. Less than 1% of the patients on the osimertinib got a brain metastasis, 9% in the patients in the placebo arm. So protecting you from getting brain metastasis was a big gain. Now, this is the data that we have for overall survival. It's very minimal because only 5% of the patients have mature data. At least they had it, and when they presented this in 2020, again, we're waiting for the data to be more mature and see if this is really impacting overall survival or not. Now, for patients who don't have a driver mutation, they don't have an EGFR. Let me back up a little bit. There are a lot of clinical trials looking at inhibitors for RES, RET, ROS, and some of the other inhibitors in patients who have resected lung cancer. So consider that if you have a patient who has a driver mutation and had surgery, and then you complete adjuvant chemotherapy if needed. Now, for the patients who do not have a driver mutation, this is the new data, and this is the IMpower010. This was presented at ASCO and then has been presented again at ESMO a couple of weeks ago. Patients who have a resected lung cancer and that went from stage 1B through stage 3A, they had adjuvant chemotherapy, and then at the completion of the adjuvant treatments, if required, those patients were randomized between a year of atezolizumab or best supportive care. And the endpoint was the same as the ADAURA trial, disease-free survival, investigator-determined disease-free survival. The study was positive. You see that in the Kaplan-Meiers, this is the one in the center, the numbers are 70.2 compared to 61.6, so there is some separation of the Kaplan-Meiers. And this is valid in the intention to treat, and it's really good if you have a high PD-L1. Now, when you look at the hazard ratios, the numbers are not as good as in the ADAURA trial. So these hazard ratios are getting close to 1. So, you know, not the most impressive hazard ratio, but there was a subset of patients that did not benefit it. Basically, the never smokers, we know that they probably have a driver mutations. Patients with a known driver mutation, such as EGFR or ALK. And the group of patients who had the most benefit are the ones who have high PD-L1 expression. More than 50% PD-L1 expression was a good predictor. The side effects that led to discontinuation of the immunotherapy was seen in only 18% of the patients. And again, the type of side effects that you see are the same ones that we see when we treat these patients. So this is where we are now. We are at the point that immunotherapy is showing to work. It works better if you give it with chemotherapy. What we need is to wait for these results. I think we're going to see a higher impact of immunotherapy for the group of patients who had received some chemotherapy plus immunotherapy, followed by surgery, followed by that year of adjuvant immunotherapy. The IMpower010 is just adjuvant immunotherapy. Those patients did not receive any neoadjuvant chemo plus immunotherapy. Thank you.
All right.
I have the honor to introduce our next speaker, Dr. Charu Agarwal. Dr. Agarwal is an associate professor at University of Pennsylvania with her focus in lung cancer. She did her residency at University of Buffalo and then moved on to do her fellowship at Fox Chase Cancer Center. Her clinical research focus is novel immunotherapies and discovery of biomarkers. She's also involved in cellular therapy and CAR T cells for solid tumors. So without further ado, I will invite Dr. Agarwal. It's a privilege to have her here. She's going to join us virtually. Thank you.
Can IT switch on the volume?
Hello, everyone. I'm Dr. Charu Agarwal. I'm the Leslie Heisler Associate Professor for Lung Cancer Excellence at the University of Pennsylvania's Abramson Cancer Center. I would like to thank Dr. Jaze and the organizers for inviting me to present today on updates on metastatic non-small cell lung cancer, updates from ASCO annual meeting of 2021. So before we begin, here are my disclosures. For today's talk, I would like to focus on three broad categories. I would like to talk about certain practice-changing abstracts, including reports on agents targeting KRAS G12C and EGFR exon 20 insertion mutations. Would like to then focus on potentially practice-changing updates, looking at the oral abstract presentation from Empower 010, evaluating the role of atezolizumab in the early stage management or in the management of early stage non-small cell lung cancer. And then finally, looking at some practice-affirming data analysis from the FDA, the Pacific 5-year update, and a small cell lung cancer trial called the CLGB 30610. So without further ado, I'd like to start with the first practice-changing abstract. Sotorasib is a first-in-class oral therapy that selectively and irreversibly targets KRAS G12C mutant protein. And this has been a long time coming. This has been a previously undruggable target. We know that KRAS G12C is quite common in non-small cell lung cancer, accounting for about 13% of all patients with metastatic non-squamous non-small cell lung cancer. And sotorasib affects the intracellular domain. In December 2020, it received breakthrough designation for use in these patients and finally was approved a couple of weeks prior to the presentation of these data at ASCO. The approval is based on the results of the CODEBREAK 100 trial. The design is illustrated here. Patients with locally advanced or metastatic non-small cell lung cancer harboring a mutation with KRAS G12C, having progressed on prior standard therapies were enrolled. Stable treated brain metastases were allowed, and sotorasib was administered at a dose of 960 milligrams once daily. Radiographic disease assessment was performed every 6 weeks and then every 12 weeks thereafter, and primary endpoint was overall response rate. Summarized here are demographic criteria for demographic characteristics of patients enrolled onto this trial. And you will see median age was about 63.5 years. And predominantly patients had been treated with a prior platinum and or PD-1 or PD-L1 therapy. 93% had a history of smoking, and about 57% of the patients had received 2 or more prior lines of therapy. We saw that overall response rate was 37.1%, including few complete responses. Median progression-free survival for the single-arm trial was 6.8 months, with a median overall survival of 12.5 months, which is very significant in terms of really providing a durable benefit for patients with metastatic non-small cell lung cancer. Most patients did have a response at the first scan. Here you will see that the time to response was about 1.35 months. Looking at some subset analyses, and again, these are hypotheses generating and not clearly practice changing, but it does appear that patients who may have had prior PD-1 or PD-L1 therapy, but no chemotherapy, again, the numbers are very small, only 13 patients here in this data set, the median overall survival was quite high at 17.7 months, with an overall response rate of 70%, really underscoring the importance of sequencing and perhaps using monotherapies in select group of patients that may have high PD-L1 expression. We also learned a little bit about the occurrence of co-mutations, and STIC11 and KEAP1 mutations often co-occur with patients with KRAS mutation. And we can see that the response rate goes down if patients tend to have tumors that are both STIC11 and KEAP mutant, with a response rate of only 23%. However, the response rate does seem to be highest in patients that may have a STIC11 mutation but KEAP one wild type. So I think in the future we'll get an assessment or get a window into treatment options for patients based on co-occurring mutations with KRAS G12C. This drug is now approved, and we are using it in the clinic. Again, just to remember that this is approved for second line and beyond. Moving on, while not presented at ASCO, I think this is a very important update to present in metastatic non-small cell lung cancer. We heard about it first at the World Lung Cancer Conference in 2020. And recently, amivantamab has been approved for patients with EGFR exon 20 insertion mutations. So what is amivantamab? It is a monoclonal antibody that binds to the extracellular domain for EGFR. It received breakthrough designation in March 2020 and received FDA approval in May of this year. The data really comes from the Chrysalis trial, which was a trial designed in the post-platinum setting for the exon 20 insertion population, initially designed as a dose escalation study where patients received 140 to 1750 milligrams of amivantamab. And then once the recommended phase 2 dose was reached, patients underwent treatment in this dose expansion cohort for EGFR exon 20. Key eligibility criteria are listed here. Patients needed to have metastatic disease with exon 20 insertion and must have progressed on platinum-based chemotherapy. A total of 114 patients were enrolled, and 81 patients were evaluated in the post-platinum setting. Overall response rate was the primary endpoint. And as you will see here, best overall response rate waterfall plot is shown on the left. Responses were seen in the majority of the patients, irrespective of the type or the place for exon 20 insertion. Overall response rate was 40%, with a median duration of response of 11.1 months and a clinical benefit of 74%. Before moving on to potentially practice-changing abstracts, I will say that amivantamab is currently approved as a single agent, however, is being evaluated in combination with lazertinib, which is a third-generation TKI, in patients with EGFR sensitizing mutations. So there's a slight difference here in terms of what the indication for approval at this point is. Empower 10 is a potentially practice-changing study. We know that adjuvant chemotherapy provides overall survival benefit in patients with resected lung cancer, but can immunotherapy provide a benefit? And here we saw this phase 3 trial that looked at addition of atezolizumab post chemotherapy for 4 cycles. 1,000 patients were randomized to either atezolizumab or best supportive care, and investigator assessed DFS was the primary endpoint. And as noted here, you can see that disease-free survival in the PD-L1 positive population was improved. Hazard ratio for DFS was 0.66. And this seemed to be the case more so for patients that were PD-L1 high. As you can see, PD-L1 greater than 50% had a hazard ratio of 0.43. In the stage 2 to 3A, in all comers, the hazard ratio seemed to be 0.79. Again, I think emphasizing that we may need to select these therapies based on PD-L1 or other biomarkers. Overall survival data is immature at this point in time, but I think this is important for us to know and just sit back and take in these data a little bit. This is the first phase 3 study of immunotherapy in the adjuvant setting to really show a DFS benefit. It's seen in PD-L1 positive, higher in PD-L1 greater than 50%. I would consider it in patients with no actionable mutations, patients who have a history of smoking or have high PD-L1. And ultimately, I think this will be a shared decision-making amongst patients and physicians regarding the pros and cons of adjuvant immunotherapy. And we await further data, including overall survival. Moving on to practice-affirming data. One of the main questions in management of patients with wild-type non-small cell lung cancer is, how do you treat patients with PD-L1 1 to 49%? So while it's clear that for patients with PD-L1 greater than 50%, we could use monotherapy, we quite don't know whether we should use monotherapy for the 1 to 49%, or should all these patients be treated with chemoimmunotherapy. So what the FDA did was they looked at this question with an exploratory analysis of all trials that evaluated populations of patients with PD-L1 1 to 49%. They asked, is there a difference in overall survival for patients that receive chemo-IO versus IO? Is there a difference in PFS? And they looked at subgroups of age, performance status, and history of smoking. They pooled data from randomized controlled trials, and they included those trials with the PD-L1 tumor cell expression only. There were 2 trials of immunotherapy and 6 trials of chemoimmunotherapy, a rather large population of 2,100 patients. And here's what they found. They found that patients with 1 to 49% tend to do better in terms of overall survival when they receive chemo-IO, as demonstrated here in on the left in red. And median progression-free survival is also higher for patients that receive chemoimmunotherapy. Further breaking down some of the subsets, they found that patients greater than 75 years didn't really have a worse outcome with chemo-IO-therapy. So in summary, these data affirm my practice to use chemo-IO in patients with 1 to 49% expression. And we need further biomarkers to define subsets of patients that may benefit from immunotherapy alone. Moving right along, we all are very familiar with the data from Pacific. This established durvalumab as the consolidation therapy for patients following concurrent chemoradiation in the locally advanced, unresectable, wild-type non-small cell lung cancer setting. We saw 5-year updated data, and really humbling curves here. I do think that we are extending the benefit of cure to patients with the use of durvalumab. Here you will see overall survival at 5 years still higher for patients that received durvalumab, 42.9% overall survival at 5 years compared to only 33% with the use of on the placebo arm. Hazard ratio is 0.72. And you can also see that the PFS is much better, again, signifying a majority of these patients are actually remaining disease-free. Incredible data, and I think this, again, affirms our practice to use durvalumab in this setting. Lastly, I want to just talk about role of radiation therapy scheduling in small cell lung cancer. In 1999, Teresi et al. Demonstrated that 45 gray BID was superior to daily radiation therapy for limited stage small cell. However, practically, twice-a-day radiation is quite difficult to deliver. So the CLGB trial was designed to test superiority of 70 gray everyday radiation versus 45 gray twice-a-day radiation for limited stage small cell lung cancer. And here's the design. And you will see that the overall survival data, as reported here, show that 45 gray BID did come back at 28.5 months, and arm B, which was the 70 gray QD, came back at 30.5 months with no statistical difference. 2-year and 5-year overall survival rates are listed here. Again, I want to emphasize that this is a trial that took a long time to accrue, and we have a long follow-up here. Median follow-up is 4 years, yet we're not seeing really a significant difference in overall survival. Progression-free survival also does not seem to be significantly different. So what is the conclusion from this? One conclusion is that BID radiation remains the current standard of care. However, even though this was designed as a superiority trial, does this actually give us an opportunity to say overall survival is the same with daily radiation? Can we adapt daily radiation into our current practice? In the future, I think we will need to consider patient factors in an attempt to personalize radiation therapy for limited stage small cell lung cancer. So in summary, KRAS G12C mutant non-small cell lung cancer is now actionable. We have data from the use of sotorasib. EGFR exon 20 insertion mutations are also actionable. Now we have amivantamab single agent approved for this indication. Empower 010 is the first phase 3 trial to demonstrate a DFS benefit with atezolizumab in stage 2 to 3A non-small cell lung cancer following surgical resection and 4 cycles of chemotherapy. And then some practice affirming data. FDA Analysis affirms our practice to use chemo-IO in patients with PD-L1 1 to 49%. Pacific 5-year outcome supports standard of care use of consolidation durvalumab. And then everyday radiation is not really superior to BID radiation for limited stage small cell lung cancer. With that, I would like to thank you for your attention, and I'm happy to stick around for questions during the live Q&A session. Thank you so much.
Dr. Agarwal, we have Dr. Molina come back to the podium.
So I'm going to be talking about something that is close to my heart, and it's a small cell lung cancer. Sometimes you don't marry the right person, but I have a track record of 6 negative studies for small cell lung cancer. We try everything: SRC inhibitors, c-KIT inhibitors, different ways of giving chemotherapy. Even a really promising thing, which was an oncolytic virus called the Seneca Valley virus. I have to tell you a story. I have 2 patients who were alive and well at 2 years. We're comparing this to placebo. And when we finished the trial, my 2 patients were in the placebo arm. So that was frustrating. I'm going to start by giving you kind of the best evidence about what is that we're doing and what are the things that are changing for the treatment of a small cell lung cancer. I'm going to start with limited stage. And I want to call the attention that some of these patients are actually surgical candidates. So this was a study done in about 15,000 patients. They look at probably patients that went to surgery and then they learned that they have small cell lung cancer after the surgery. So they look at the outcomes for patients with N0 disease, N1 or N2 disease. And you see in green how the patients who have surgical intervention, even with N2 disease, did better. There was a recent follow-up presented that at ASCO that look at the overall survival for this group of patients. Even the ones with N1 and N2 disease had superior outcomes. I circled 36.2% for the ones who have surgery versus 17.1% if you have N1 disease, 22% versus 13% for the group of patients who have N2 disease. Again, calling the attention that surgery may have a role for patients with early stage small cell lung cancer. In 2016, we incorporated this into the guidelines. Now, the point is this: if you think that your patient is going to be a surgical case, you need to do a very good staging of the mediastinum. If the mediastinum is involved, then the patient is treated with concurrent chemotherapy and radiation like we treat limited stage. If the mediastinal staging is negative, then it's okay to proceed with surgery. At the time of the surgery, the patient is N0, that patient still needs 4 cycles of cisplatin-based chemotherapy. Cisplatin seems to be superior to carboplatin for limited stage small cell lung cancer if the patient can tolerate it. For N1 and N2 disease, that patient needs to go ahead and complete concurrent chemotherapy and radiation, meaning the standard treatment. Now, there's some controversy about the N1s. Do they really need radiation or they don't need radiation? But I think this needs to be discussed with each patient based on how the patient looks. Again, that's the role for surgery in the early stage. Now, for patients who receive concurrent chemotherapy and radiation, then the question is, if you have limited stage, do you benefit from receiving immunotherapy after completing concurrent chemotherapy and radiation? And this is the result of the CheckMate 032. This was, again, published in the Annals of, presented at ASCO and published in the Annals of Oncology. What they did was patients who have limited stage small cell lung cancer, meaning stages 1, 2, and 3B, that the radiation oncologist felt that it was limited disease. They were randomized between Nivo, EP, and then followed that by nivolumab for a year versus observation. So I want to call the attention of the point that this regimen is using EP. And I'm calling this because for lung cancer, we don't really understand how blocking CTLA-4 works, and it's problematic. Most of the studies that use CTLA-4 inhibitor have been negative studies, with the exception of some of the CheckMate studies using this with chemotherapy. So these are the results when you look at progression-free survival. What they presented at ASCO, it was a 43.2 versus 40%. So not what they wanted. So they didn't achieve the progression-free survival that they wanted for this group of patients. And then the final report was published only a week ago in the Annals of Oncology. And as you can see, the study did not reach the intended progression-free survival. Okay, all what this is telling us is that immunotherapy with a combination of EP plus Nivo, after you have, definitive treatment with chemotherapy and radiation for limited stage small cell lung cancer, is not working. That doesn't mean that one of the other PD or PD-L1 inhibitors is going to work, or if you add that immunotherapy to the concurrent regimen, that's going to give you a positive result. So there are multiple ongoing trials. If you have patients with limited stage small cell lung cancer, please consider enrolling patients in one of these trials. For extensive stage small cell lung cancer, remember this is when the patient has metastatic disease. If the patient has a malignant pleural effusion, that is an automatic extensive stage. We have finally good news. And I'm saying this because 3 years ago, with one of the fellows, we put a paper where we titled the paper 38 years without good news for small cell lung cancer. This is how long it took us to get something. And the good news came from 2 immunotherapy studies, Empower 133 and the Caspian studies, 2 studies that were designed in a very similar way. The Empower was using atezolizumab. So these are patients with extensive stage small cell lung cancer. They were given concurrent chemotherapy and radiation, 4 cycles of concurrent chemotherapy and immunotherapy, 4 cycles of chemotherapy. After those 4 cycles, if the patient was not progressing, then those patients went ahead to receive atezolizumab, and the atezolizumab was maintained until there was evidence of disease progression or unacceptable toxicity. The group of patients who were randomized to the placebo arm just received chemotherapy, and this was followed then by placebo. And if you see here, the endpoint of the study was overall survival. At 1 year, there was a significant gain in overall survival, 51.7 versus 38.2 in favor of the atezolizumab arm. And then there was also a benefit effect on the progression-free survival seen at 6 months and 12 months. Now, the Caspian study had a very similar design. They used Durva plus chemotherapy, or they were also testing Durva plus Tremi plus chemotherapy, and that compared to the control group, who was chemotherapy alone. The endpoint of the study, again, overall survival with a secondary endpoint of progression-free survival. Now, The positive part of the study was durva plus chemotherapy. The doublet immunotherapy did not provide a positive study. Again, calling the attention that we don't know well what's going on when you add a CTLA-4 inhibitor, at least for small cell lung cancer patients. And you see, this is the updated overall survival. This was presented at ESMO a couple of weeks ago, showing that at 3 years, there's still a benefit on this for this group of patients that receive adjuvant, that receive immunotherapy. And again, that benefit is 17.6 compared to 5.8. These numbers are very good. Have a database of patients with extensive stage small cell lung cancer. We have close to 6,000 patients. We found 75 5-year survival, 75 that survived the disease. Now, it's difficult to compare two studies, but these two studies were almost identical. The Caspian study is the one that is using durva. The Empower study is using atezolizumab. You see at the demographics, they are very similar. The number of patients with brain metastasis, smokers, performance status, and median age. When you look at the results, again, they are very, very similar. The results of durva plus chemotherapy, they give you an overall survival of about 13 months. 12.3 months for atezo plus chemotherapy. Again, very similar results. Response rates are, again, very similar, 67.9 versus 60.2. There's a little bit of a difference. For the Caspian study, they did allow patients to continue chemotherapy for 6 cycles. In the empowered patients, after 4 cycles, they completed that chemotherapy in the control arm. But again, the two studies are very similar. The two agents are FDA approval, so it is up to you to decide if you want to use atezolizumab or you want to use durvalumab. Now, immunotherapy not always works, and there are examples that. Let me start with the one on the right. This is the Keynote 604. So we participated in this study. This was Pembro, same design as the Caspian, same design as the Empower, adding immunotherapy with pembrolizumab to carboplatin plus etoposide, 1-to-1 randomizations. The endpoint was overall survival, no difference in overall survival. There was a trend towards improvement of progression-free survival, but this was one of the few negative studies for pembrolizumab in the field of lung cancer. Now, Checkmate 451 was a different study. They took patients after they completed 4 to 6 cycles of chemotherapy. So those ones with a response, either partial response or stable disease, were randomized to receive Nivo plus Ipi, or just placebo. Endpoint was overall survival, no benefit to overall survival. So again, showing that these two agents failed for the first line. Now, for relapse small cell lung cancer, what is that we can do for our patients? There was a study looking at going back to the original chemotherapy regimen, that is carboplatin plus etoposide, and that was compared to topotecan. Again, this is for patients with platinum-sensitive disease. And when you look at progression-free survival, going back to the original carboplatin plus etoposide is better than topotecan. There is no effect in overall survival. Everybody suspected this. Very few agents actually impact overall survival for patients with small cell lung cancer, but this was better. I'm sorry, I'm so used to these things that I went for a colonoscopy and they asked me, remove your mask. And I was, are you sure you want me to remove my mask? I'm willing to remove everything else, but let me keep my mask. I apologize. I'm sorry. So these are the results of the carboplatin plus etoposide again. So you get better responses. You get partial and complete responses that are better than the ones that you get with topotecan when you use this agent. So if you look at the guidelines, you're going to see on the right side, if you have a patient with small cell lung cancer that has had a response for more than 6 months, go to the original regimen. So that is the indication that is listed under the NCCN guidelines. Now, lurbinectedin is the new player in the field of small cell lung cancer. So lurbinectedin, which is, if you look at the chemical structure, this is close to trabectedin, that agent that is used for the treatment of sarcomas, was tested in a phase 2 study. And this was a single arm, like we used to do studies for small cell lung cancer. Patients were allowed to have 1 prior therapy treatments, and then they were given lurbinectedin. The dose is 3.2 milligrams per kilogram given every 3 weeks. Now, when you look at the results for the overall group of patients, If you add those numbers, partial response plus stable disease, that gives you the disease control rate, which is actually very good, 68%. Now, when you look at the platinum sensitive, the one on the right, these are the ones that usually give you the best response. That disease control rate is 81%. So those numbers are actually very good. And this agent actually is not that difficult to tolerate for patients. Progression-free survival is also good, at least in that study. And based on these results, the FDA approved this agent. So this agent is now available when we treat our small cell lung cancer patients. We usually start about 2.6 milligrams for the first dose. If the patient tolerates well, then we go through 3.2. But again, toxicities are not that bad when compared to the toxicities that you see with topotecan, which is the competing agent. Now, this was presented at the ISLAC World Lung Conference about a month ago, and is the Atlantis trial. So what they did was to use lurbinectedin at a lower dose, 2 milligrams per kilogram of body weight, plus doxorubicin. And these treatments are given every 3 weeks, and this was compared to the standard, the FDA-approved topotecan. And when you do studies and you use topotecan, it's like when you do studies in non-small and you use docetaxel, the study is going to be positive because those two agents are really lousy. So the results of the study, believe it or not, did not show any increase in improvement of overall survival. So again, like many things that we do for small cell lung cancer, not really benefit that translate to improve overall survival. However, when you look at the table on the left, the toxicities with this regimen are much better than the toxicities that you get with single agent topotecan. There is less hematologic toxicity. The non-hematologic toxicity is very similar to topotecan. So, they are pushing for this regimen as a regimen that is easier to be tolerated if you are concerned about your patient being able to tolerate lurbinectedin at the usual dose of 3.2 milligrams. My argument is, why don't you just lower the dose of lurbinectedin and your patient will tolerate it the same way? Now, immunotherapy for these patients with relapsed small cell lung cancer has a very limited role. So I see a lot of people using immunotherapy after you progress on immunotherapy for extensive stage small cell lung cancer. There are plenty of studies showing that this actually doesn't do much. Checkmate 331 and Checkmate 3032 were using Nivo, and they did not provide results superior to topotecan. And then pembrolizumab was also tested in this setting, and the results were not that promising. Let me use a minute to talk about mesothelioma. What happened in the last year for mesothelioma? We got the final results from the Checkmate 743. This is a study that was looking at dual immunotherapy, Ipi-Nivo, compared to chemotherapy for patients with mesothelioma, all histologies. And you see in blue how the patients who got immunotherapy got a superior outcome. So overall survival is improved at a year and then improved at 2 years. Now, when we look at how was the overall survival by histology, the group of patients who received the most benefit was pretty much the sarcomatoid and the mixed histology, what we call the non-epithelioid histology, but the regimen is still effective for the epithelioid. So this is important news because we knew that pemetrexed-based regimen had very little activity for the non-epithelioid, and those were more active for the epithelioid. But nowadays we have two options for patients with mesothelioma. They can get dual immunotherapy or they can get a pemetrexed-based regimen. And the dual immunotherapy seems to be better for the non-epithelioid, but still having good activity for the epithelioid. This is all what I have. Thank you so much.
We have two questions for the audience. In real life, which subgroups of patients with early lung cancer would you send for neoadjuvant therapy versus direct surgery followed by adjuvant?
Yeah, so what happens in real life, and I'm going to tell you how we do the practice, is we talk to the patient. So we kind of discuss this with the patient. You're potentially a candidate for a clinical trial where we're going to be testing chemotherapy plus immunotherapy for 4 cycles followed by surgery. And then this is going to be compared to chemotherapy plus placebo. And then after the surgery, you're going to get either immunotherapy or placebo. In some patients, when you mention the word placebo, no, I don't want that. I need to have the guarantee that I'm going to get the immunotherapy. So we kind of let the patient decide who's going to go one way or the other. I think there's going to be a lot of selection biases when we see the results from these clinical trials. Probably patients that have better performance status are the ones that are going to get, the whole sequence of neoadjuvant chemo, surgery, and then adjuvant. But we still have to wait for the results.
Before I ask you the second question, it's noisy. Dr. Jazzy asked to be stay right after Q&A because there's a group picture, so don't run off yet. So they take a picture. The second question is, which patients would you think would qualify for perioperative radiation therapy?
Well, I'm going to disclaim that I'm not a radiation oncologist. There are clear indications for radiation therapy, and those are if you have a margin that is positive, if the surgeon has any concern about the margin being very close. I think nowadays there is more question about the need to proceed with adjuvant radiation for patients with N2 disease, particularly when you have just one station or one zone involved as opposed to multiple stations involved. So what I do is I just pass the question to the radiation oncologist. I tell them, well, we have dedicated thoracic oncologists. They know this better. Go and talk to the radiation oncologist and see if they recommend radiation or not.
Thank you.
I want to actually pass that question also to Dr. Agarwal, who is joining us. What do you do in your practice, Dr. Agarwal?
So I agree with you, Dr. I agree with you that there are a couple of instances where we think perioperative radiation therapy is definitely indicated, as you pointed out. I think in the case of a positive margin, where the surgeon even if it's not pathologically positive, I mean, that's a direct indication. But even though sometimes we see pathology reports without a direct mention of a positive margin, and the surgeon feels that they were very close. Those are indications where we discuss this in multidisciplinary tumor board and do come in and offer concurrent chemoradiation in the perioperative setting. And then lastly, I would say that in the presence of N2 lymph nodes, we do come in with postoperative radiation therapy where, the data I think is mixed now in terms of does it really provide you durable, distant survival benefit or distant recurrence-free survival benefit. And I think it's an evolving area, but at our institution, we still prefer to provide port for patients with N2 disease.
Any questions? Stay here for the audience. Yeah. All right.
For non-small cell cancer, we know the role of radiation in stereotactic 3 to 5 fraction is as good as surgery for early stage 1 or so. As shown by MD Anderson, recent article. Also, it's very good for a locally advanced disease with chemoradiation followed by 1 year of Deveromap. So what do you see the role of radiation for non-small lung cancer in the future?
Dr. Agarwal, do you want to take this?
I think we're going to be using radiation more and more in the future. I mean, already many of our patients with locally advanced non-small cell lung cancer, who 3 or 5 years ago we would have tried really hard to take to surgery. Now we are saying and more comfortable with saying, okay, let's go with concurrent chemoradiation and follow it up with durvalumab. So I do think that the role of radiation therapy is becoming more important. And I will also point out that in the case of oligometastatic disease, we are routinely using radiation therapy, either stereotactic radiation or other approaches routinely. And I think coming in with re-radiation approaches much more boldly than we did 2 or 3 years ago.
Yeah, I just want to stress that we're using the radiation oncologists more and more nowadays in lung cancer, not only for non-small, but also for small cell lung cancers. I'm trying to stay away from sending the patient with small cell lung cancer for prophylactic cranial radiation because I think the data is not the best data. And we know for extensive stage, the data, we just tell those patients that we're going to follow them with serial MRIs. And for limited stage, I have the discussion with the patient, and I usually ended up just following the patients with MRIs, as opposed to sending them for prophylactic cranial irradiation. Right. Yeah. When they do the radiation, they tend to protect the hippocampus.
Well, we thank you, everyone. In order to keep everything on time, we thank you, our guest speakers, and please stick around for the picture.
Thank you.
So thank you very much for a great session. So if you don't mind everybody to come forward, we'll make 3 lines. So people will be on stage, and then line standing up, and then line of chairs. For those of you who are joining us, virtually, you can take a break. You can take a selfie and send it to us if you want, but it's a break for you guys who are joining us virtually.